recording.
All right, sounds good. So you said mostly M1s and M2s, right?
Yep.
And mostly people that want to go into ortho, as I understand. Is that correct?
Yes. Yeah. It was down to the whole ortho interest group.
Gotcha. Okay. Well, for everyone here, my name is Wylie Lopez. I'm currently a spine fellow at Rush. I was a Rutgers undergrad and Rutgers medical student as well. And I was asked to talk to you guys about my journey into spine surgery, my journey into orthopedics and then spine surgery. And then we can talk a little bit about spine and show you some cool cases. And we can talk a little bit about anatomy. And, I'm not sure where all your learning are. So we'll make this pretty simple when it comes to the spine stuff. And feel free to call out stuff if you know answers. I'm not really going to be calling on anybody or anything. So, this PowerPoint is just to give you a little bit of an idea of my life. So I was born in Puerto Rico. I was actually born in Ponce, which is right here. We didn't live there for very long. My family moved to Cartagena, Colombia when I was 1 or 2 years old, and we lived in Colombia for about a year. And then, from there, we moved to New Jersey, and that's me. And I'm from Somerset, New Jersey. I went to Somerset High School, Franklin High School. And you guys probably know Somerset. I mean, it's the town right next to where you guys all go to med school. For the most part, I guess it's a good town. But the area that, my family lived in was kind of sketchy. It was like on the border of New Brunswick. And, we didn't have much money growing up. So we kind of lived in a rough sort of area. And just to give you guys an idea, this is my crew growing up. All right, that's my brother in the middle. And these are all my best friends. And yes, we were part of the white t-shirt gang. No, we weren't, but that's kind of how kids dressed back then. It's kind of scary to look at now. But it's, these are the people that I grew up with. And that room that you're looking at is my brother and I's shared bedroom, really small, right? So, when I think of orthopedics now, it's much different than what I thought about it when I was in your shoes. I always thought that it was like the really well-off, super smart kids who like get into this field. But I'm going to show you that that's not necessarily true, depending on how hard you want to work and, just being a good person. But, this picture's sort of funny. My brother in the middle there now owns his own business. This guy on the left making the kissy face is now a police officer in Somerset. This guy became a big shot IT dude at his job. This guy became a sort of bigwig administrator at a hospital. And unfortunately, this kid became addicted to drugs and sort of had a really hard life. But, these are the people I grew up with. And my school, people were getting shot and killed. People were getting stabbed. It was pretty crazy. And it was, the crew that we were hanging around with, we were kind of some badass kids. We would just kind of roam the streets after school. My mom and my dad split up when I was pretty young. And so, mom would come home pretty late. She'd be tired. And, there'd kind of be no one at home for a while. So we would just be out in the streets playing basketball or fighting or whatever. We were just kind of crazy kids. And this is really what got me out of trouble, really, was sports. I always had affinity for sports. And I started wrestling, and I was good at it. So I kept doing it. And my coach was basically like, look, I know what you're doing after school. And if you're going to keep doing that stuff, like, you're off the team, and I'm just going to rat you out to the principal myself. And so basically made a deal with him to stop doing that and keep playing sports. And so he convinced me to play football. He convinced me to play baseball. And I kind of just turned into a jock and was able to get off the streets and away from the crazy stuff that we were kind of doing growing up. And, I was an average student. I was, like a B student. But luckily for me, even though I didn't have the best relationship with my dad growing up, he was still in the picture, and he was a maintenance man at Rutgers. And because of that, I was able to get, tuition remission at Rutgers. And that's the reason I was able to go to college. So it's kind of crazy to think about, he's just kind of fixing air conditioners and refrigerators. And because of that, I was able to launch the career and sort of where I am now, which is kind of crazy to think about. But, when I got to Rutgers, I had no idea what the hell I was doing. All right. I had very average grades in high school. I did so poorly on my placement test that I got placed into intermediate algebra, which is actually a prerequisite course to have the real Rutgers math course. So I already started way behind. Okay, so far behind that it took me an extra year to finish college, just so you guys are aware. And so, I had no idea what I was doing. I was kind of just scraping by. I was about a B student, getting C in math. And, it was kind of rough in the beginning. And then I found this program called Audacious at Rutgers, which sort of helped me buckle down. They taught me how to study the right way. And, once I started studying the right way and started getting the grades, I was like, oh, maybe I can actually, do this thing that I've always had in the back of my mind. And that was to become a doctor. And so, there was a lot of hard work that happened in between, that Rutgers picture and me getting into medical school. But you guys all know how that story goes. You work really hard. I had a lot of help along the way. I was able to meet some mentors in college that were able to kind of show me the ropes and show me how to do the right things to get into school. And because of some of the connections I made, I got a full scholarship to med school. And so, I wasn't the smartest guy. I didn't have the best grades ever, but I utilized all the connections that were available to me. And you'd be surprised how far that goes in this field. And identifying mentors is crucial to what you guys want to do. I say that because you don't necessarily have to be the one with like the crazy board scores or like all the publications and stuff, and I'll give you an idea of sort of how my application looked going in and why I got to where I got. But, when I got to med school, that's it. Gloves off. I promised myself that I would study like crazy all the time. And I still went out and I still did my thing and still had fun, but, I worked really, really hard. And I didn't realize that I wanted to do orthopedics until my third year. So a lot of you guys are like way ahead of where I was, and I didn't have any research. I was like way behind when I figured out that that ortho was the thing I wanted to do. And so after my first year of med school, I found a research position at Mass General, and I just randomly applied for it because most of the people that I knew who were in my med school class were traveling the world and doing all this crazy stuff at the end of their first year. And I was broke, I was poor. So I was like, all right, I'm just going to go do research or something. Hopefully I can get a spot. And I was lucky enough to get a spot at MGH doing research with an ophthalmologist, which is not the right O, as you're aware. But as that date approached, the ophthalmologist got really sick. And all of a sudden he told me he couldn't take on a student. He wasn't going to be around for the summer. And so I was like, oh crap, there was my plan. Like, what do I do now? And so I just started reaching out to random people in the research department at MGH, and someone linked me up with an orthopedist. And the orthopedist that I got linked up with at Mass General is now one of my closest mentors and friends. And so, you just got to put yourself out there, and you have to be willing to make friends and be willing to kind of get out of your comfort zone and do things that maybe you weren't even thinking about. I wanted to be an ophthalmologist, but I said, a summer research position is better than no research position, even though it's in a field that I, wasn't particularly interested in. But then after doing it for a summer, anyone who starts to do ortho is like, yeah, this is the best, So I fell in love with ortho. I spent a summer in Boston, fell in love with Boston and sort of knew where I wanted to be. And because of that guy, I had my foot in the door at the Harvard program. And so, you bring the grades, you bring the step scores. I don't know if they're still counting the step scores or what's happening with that anymore, but, there are still ways to distinguish yourself other than being the person with the highest scores and everything. So, I honored a lot of my classes. I got AOA the second time around. So I wasn't like the first wave of people that got AOA, those like super smart guys. But I ended up getting it the second wave. And, I did decent on my step score, but having that mentor after my first year of med school and staying in touch with him and constantly, updating him on sort of what my status was and what my scores were was huge. All right. If it wasn't for that, I don't think I would have gotten into the Harvard program. And I did my residency at Harvard combined. It was awesome. And to be honest with you, when I got there, I was like, ooh, do I belong here? These people seem a lot smarter than me. But, ultimately, you work hard and you put your head down and you can go wherever you want to go. And so, this is me graduating med school, and you guys will get this soon enough. This was like the best feeling on earth. This was like in the middle of the street in New Brunswick. It looks like, something crazy just happened behind me, but this is why you work so hard. And by then you'll know where you're going to be in residency. And this is, this makes all the hard work. You can feel it when you have this moment. And at this point, it was so surreal to have my family there, considering how we grew up and sort of what the expectations were growing up. No one expected me to go to college. It kind of just happened. No one expected me to go to med school. It kind of just happened. And then, no one especially expected me to go to Harvard, and I ended up there. And, I keep saying this to you guys because it really doesn't completely matter for you to be the top person in your class. Connections are super important. And these are connections that you can make on your own. It's not like you have to go begging people to introduce you to other people. I just started messaging people and asking for research positions and seeing what was available, and you'd be surprised that some people will actually be willing to go to bat for you that you don't even know. And so, eventually I made my way to Boston for my residency program at Harvard. And residency is like the coolest thing ever. Especially, ortho residency is hard. I'll tell you guys, it's physically demanding. You will be tired. You'll be on call a lot. You'll get your butt whooped. You're going to have your down days, but you're going to have your days where you get to operate and do cool stuff like this. And it makes everything so worth it. And, it really doesn't matter where you go for residency. If you get into an ortho residency, you win. Okay. So, don't be upset if you don't get your top choice. It really doesn't matter that much. Maybe it matters for the city if you really wanted to end up in a city, but let's be honest, there's tons of people applying for ortho positions. So if you get in, be happy. Okay. So, this is me, my 4th year doing a hand surgery case, knowing already that I didn't like hand surgery that much. So that's why I'm not smiling. But it's still awesome. It was probably the best 5 years of my life, to be honest with you, because, I met my wife there. I got married while I was in residency. I got married in Puerto Rico, kind of bringing it back. And, this bald guy here, this out of place sort of white bald guy with all the Latinos, this was my mentor, Kevin Raskin. He's the guy that I met my first year of med school. And this guy really moved mountains for me. And I didn't do anything particularly exciting. The summer that I spent with him, we didn't publish anything. He and I just kind of hang out and did some cases and got food and just like broed out the whole time, and it's just a connection that I randomly made that made all the difference in my life and my career. And this guy is one of the closest people in my circles now. I'm applying for jobs and I call him every time I have a job interview. I ask him for advice all the time. I call him at like 9 at night. He's my boy. And so I would really stress to you guys the importance of finding a mentor, and you never know when it's going to happen. I can't explain to you how it happens, but you have to be open to the idea of looking for one and finding one. And if you identify someone either at the med school or at the hospital that you feel like you're getting cool with and can talk to on like a normal level and not feel like scared to talk to them, start reaching out to them more. Ask for their email, ask for their cell phone, start, asking them for advice. These people love being asked for advice. It's and I did it all the time, especially when I was at the med school and in the classes. I talked to all the teachers all the time. But this is my family at my H-Core graduation. And you think med school graduation is awesome. Wait till you graduate from residency. This is 5 years of the hardest you will ever work. It's extremely fulfilling. It's really challenging. And this is what your career is going to be, hopefully all of you guys. And again, I want to stress the idea here that, I didn't come from anything particularly exciting. It's kind of from like a sketchy area of Somerset. My family didn't have money. I identified mentors. I studied really hard. I did all the work that was expected of me. And, in residency, it becomes a whole different beast because it's no longer just how smart you are. It's how hard you work. And it's a different kind of work. Like when you're in med school, you have the list ready. You kind of, sort of know the patients. You kind of watch in the OR. You're not really that involved. Maybe you do some suturing. It's a whole different ballgame in residency. And if you're someone who's going to try to go and hide, people are going to know right away and you're going to be in trouble. So, the harder you work, the more people notice and the more people will want to go to bat for you. And the more they'll help you and help you get to where you want to be. And, that's what happened for me. I went on my fellowship interviews, and luckily this was before the coronavirus. So I was actually able to travel there. And I went to Chicago, and I had been there, for a wedding, but never really experienced the city before. And I was like, wow, I need to go here. I knew pretty quickly that this was my first choice. And, I told you guys, I started, I told you guys about orthopedics. I didn't want to do ortho until like my 3rd year, which is sort of late. And the same thing happened with spine surgery. I hated spine surgery when I first started. It was terrifying. because you don't learn spine surgery in medical school unless you guys are learning it now and they're doing something new. Because I didn't know anything, and all of a sudden you're the ED call resident and someone's coming in with, a cauda equina syndrome or something, and you're the first line between them being able to pee normally for the rest of their life. It's pretty scary. And a lot of it depends on your ability to look at imaging and take a good history and do a good physical exam. And so spine surgery was scary. I was like, screw that. The trauma stuff came a lot more naturally. The total hips, total knees came a lot more naturally. So I had no intention of doing spine surgery. And I figured it out really late, well into my third year, which is sort of late for residency, I guess. And as soon as I realized I wanted to do it, I started identifying people in the field who I thought had a pretty good perception of, my work ethic and my personality. And I started following them around and asking to just meet and go to their office. And, I tried to become friends with these people. I didn't do anything particularly exciting. I published here and there. But, I talked to them about my interests and what I wanted to do and where I wanted to be. And I hung around with them. I asked them to come to their clinics. Even on days where I would finish early, I had the option of going home, 12 o'clock, go to the gym, go hang out, watch cartoons or whatever. But instead, you go to someone's clinic who you're not expected to be there for, but they notice that kind of stuff, and that's the kind of stuff that will get you a letter of recommendation that's not template, and that's what you guys are ultimately looking for both residency and fellowship. And that's where, again, these relationships are really important. You guys really should do your best to meet with, if it is orthopedics that you feel like you want to do, make sure you talk to, the chairman of orthopedics. I think it's still Charlie Gatt over there, right? Yeah. So, Charlie Gatt, I knew nothing about this guy. I didn't know him at all. He didn't know me. I emailed him cold out of nowhere. Dr. Gatt, my name is Wylie. I want to do orthopedics. Can I come meet you in your office? And a couple of days later, he was like, yeah, sure. So I went there and we had sort of a weird conversation because we didn't know each other, but I kept coming back. And eventually he knew who I was. And then he would see me in clinics and see me in cases. And that's how people remember you. It's nothing special. It's your effort. You go there, you work, people remember you. People remember, if you're, not being weird, that's kind of hard to predict who's going to do that. But, if you just go to work and do your best, people notice that kind of stuff. So anyways, that stretches from med school into residency and will set the tone for people's expectation and impression of you forever. And especially in residency, first impressions are everything. So, I was able to get my first choice because as soon as I started residency, I was like an animal. I didn't mess around. But, that was sort of my story going into spine surgery. Again, I hope you guys can see that, it doesn't take like the smartest guy to do some pretty, interesting things over the years. It really depends on how hard you work, your ability to establish relationships and, know what your strengths and weaknesses are and play to them and, study hard. No one expects you to know orthopedics in med school. It's something that you have to do in your own time almost. Right. And when you start your orthopedic rotation at Robert Wood, you're not going to know anything, So what I did was a couple weeks leading up, I just started studying only ortho. And the only thing that people are going to expect of you is anatomy. Right. And that's the most important thing at your level right now anyway. So, know your anatomy, know the muscle groups, know the innervations, know the blood supplies. And, no one expects you to know all the bones in the body, like know the basic ones, even as an orthopedist, it's not like you're like the whole body bone guy. So, everything comes down to anatomy. And that's so true in spine surgery. You knowing your anatomy is going to be the difference between you indicating someone appropriately or doing a weird surgery that's going to have a patient back in your office and not better. And, the start of a sort of weird reputation in the community. So spine, just like everything, is anatomy. And so I prepared here some cases to go over with you guys. And, I realize you're really early in your training and you guys are probably not going to know what the hell I'm talking about, but, feel free to chime in, ask questions. I'll ask you some questions. You can just call them out. If I don't hear anybody calling out after a couple seconds, I'm just going to go ahead with the answer. But, this will sort of be what you guys make of it. And spine surgery is weird. I didn't know anything about it when I was in your position. And so, trying to look at this from your eyes, I would imagine this is all new. So I'll try to keep it as simple as possible. So this is one of the lumbar cases I did recently. 50-year-old lady, left buttock pain, which is classic, left leg pain. That's the classic sciatica. Okay. And low back pain. And so this lady had an L5-S1 ALIF, and an ALIF is an anterior lumbar interbody fusion for something called spondy in 2013. Do you guys know what a spondy is? Have you ever heard that word? No, that's a spondylolisthesis. Okay, and so I'm going to show you an example of that. It's basically when one vertebrae slips in front of the other one. And, that's someone right in the chat here. Yes, exactly. Michael Latito, slippage of the vertebrae. And that can cause dynamic instability. It can cause compression of the nerve roots. And so spondy is not necessarily a problem in of its own. If someone has spondy and they're asymptomatic, doesn't matter, right? In spine surgery, it only matters when there are symptoms, unless it's a tumor, an infection, or trauma. But in someone with a degenerative issue, you don't operate them unless the symptoms become unbearable. So this lady, years of buttock and leg pain. And that distribution of pain has a very specific name. It's called radiculopathy, okay? And what radiculopathy basically means is that there's a compression on a nerve root that's cutting off the blood supply to that nerve root. And so the way the nerve tells you that that's happening is by causing, shooting type electrical pain in the distribution of that nerve. So that's what sciatica is. Every time you hear your, 70-year-old, grandma or whatever saying her sciatica is acting up, it's radiculopathy. Okay. And so in spine surgery, we always exhaust conservative measures before doing anything. And I'm talking specifically again about degenerative spine surgery. Again, this is not a tumor. This is not trauma. Those things can cause instability and oftentimes have to be operated on pretty quickly. But these are degen spondy cases. So this is a generally healthy 50-year-old, unremarkable exam. I should have probably wrote it all down instead of just writing unremarkable, but your physical exam is everything. Okay. So if someone is coming into you and they have true weakness, 4 out of 5, 3 out of 5 anti-gravity weakness, that means that instead of exhausting conservative measures, you want to operate on that sooner than later. Weakness is a big problem. So weakness, especially progressive weakness, is often an indication to do surgery sooner. So when someone comes in with these problems, oftentimes we send them to physical therapy. We send them for an injection. We say, see you in a couple weeks. If you don't feel better, come see us again. And so this lady had exhausted all of her conservative measures. And so always in spine surgery, we want to give a clinical impression of what we think is going on. So the lady comes in, says, I have this shooting pain in my butt and my leg. So my clinical impression for her is left lower extremity radiculopathy. That's how we speak in spine surgery. So if you go to a clinic, if you go to someone's spine clinic and you see the patient and they tell you all this stuff in layman's terms, when you go to your attending and he says, well, what do you think? I think it's, left leg radiculopathy. And you'd be like, oh, nice. Okay, great. So now the imaging. So the imaging in spine surgery is a lot different than what you guys are used to looking at. So as you can see here, and as you saw for the patient history, this patient has had surgery before. Okay, they had an ALIF. Do you guys know what an ALIF is? Has anyone ever heard that term? Anterior lumbar interbody fusion. So it's basically this disc right here. If you can see my mouse pointer, you see these little lines, 1, 2. That is a piece of porous PEEK implant that's stuffed with bone graft that gets inserted between the vertebrae. And the whole point of that inner body, especially at this level, is one, for fusion purposes. All right. This lady had this surgery in the past because I can tell, you guys probably can't, she had a spondylolisthesis at this L5-S1 level. If you look at my pointer, here's the back of the sacrum, and here's the back of the L5 vertebrae. And you can see that the L5 vertebrae is slipped forward, especially over here, compared to the sacrum. That's an example of a spondylolisthesis. And again, not necessarily an indication for surgery unless the patient has exhausted all conservative measures and is having symptoms from that spondylolisthesis. So in this case, because it was a symptomatic spondylolisthesis, this patient got a fusion. And you'll notice that the surgeon went ALIF, and an ALIF is an anterior inner body. So that requires an anterior approach. So normally you go through somebody's abdomen to do that. You generally get a vascular surgeon. They open up the belly. I stay in there for those cases, but the attendings generally don't. The vascular surgeon mobilizes the great vessels, and then you're looking right at the disc space. Okay, so when you're in that surgery, it's actually pretty easy, but you always have to be wary of the great vessels, because if you even look at one of those things wrong, it's going to bleed like hell, and it's going to ruin your day. You're going to have to call the vascular surgeons back in the room. It's a really bad day. So you do the ALIF, but when someone has a spondylolisthesis, especially one that's unstable, you have to back up an inner body fusion. And that's why you see these screws in the back. Okay, and these are a really old style screw that I haven't seen, at all in my fellowship. So we couldn't figure out what these were for a while. So the way that you know if a spondylolisthesis is unstable or not is flexion and extension films. So as a patient moves into flexion and extension, you will notice that vertebrae sliding back and forth on the x-rays. So I'm guessing for this patient, they had an unstable spondylolisthesis, which is why they ended up with an ALIF. And the ALIF gets a screw to hold it into place here. And then they went posteriorly, opened up the entire back, and put these screws in. Okay, and these are pedicle screws. So these screws go into a part of the spine called the pedicle. And spine anatomy is something that you have to just hold the spine in your hand and look at and go over and over again. So these are your basic pedicle screws. So this lady came to us after all of this was done. And if you notice the level above, okay, very subtle, but here's the back of the L4 vertebrae. Here's the back of the L5 vertebrae. Okay, so the level above, she also developed a spondylolisthesis there. Okay, and so you'll notice these two x-rays to the side, they sort of look like regular lateral x-rays, but they're actually flexion and extension x-rays, because we're trying to determine if this is an unstable spondylolisthesis or not. This is a patient with radiculopathy, which you guys remember is sciatica, right? And a spondylolisthesis on imaging, okay? So we already talked, when someone has a spondylolisthesis and has exhausted conservative measures, oftentimes they get a fusion type surgery, okay? And so we did something, the MRI imaging, of course, have to always look at this. So for you guys, I don't know how often you've looked at MRIs yet. It's hard. You have to look at a lot of them, and you have to keep practicing and go over them with attendings. Ask attendings to point things out to you on MRIs. So this is a T2 MRI, and you'll notice T2, and I always remind myself, T2O, H2O, all the watery stuff is going to be bright on a T2 MRI. So you'll notice the fat is all white, right? The inside here is all white. That's cerebral spinal fluid. Okay, you guys can see my mouse pointer, right?
Yep.
Okay, so this is all cerebral spinal fluid, right? So that's all going to be bright. All the nerves and fat around them are bright. So to orient you guys, this in front is the vertebral body. The Mickey Mouse ears right here are the paired psoas muscles. All right, here are the great vessels. Something that you always have to look at if you're considering anterior surgery is whether the great vessels have bifurcated or not. If they haven't bifurcated at the level that you want to do anterior, do not do it, right? Because you can't mobilize those vessels. You'll also notice here sort of this kind of splotchy white looking stuff on either side, right? Those are the lumbar nerves, okay, the lumbar plexus. And these are all the nerves. This is the brachial plexus of your lower extremity. And they come through the psoas. And it's something really important to think about if you're considering a lateral based surgery, which we'll talk about. But anyways, with the MRI, the psoas, okay, these are the facet joints, and you have facet joints at each level of the spine, okay? In the middle here is we don't call it the spinal cord at this level. We call it the thecal sac. And that's a really important distinction that you have to make when you're seeing patients, because in the cervical spine, in the thoracic spine, usually ending around L1, that is the spinal cord. That acts like a one nerve, okay? After that, we call it the thecal sac because it's a bunch of rootlets. Rootlets basically floating around in a water balloon. So compression at the spinal cord versus the thecal sac causes completely different problems. your body is much less able to adapt to compression at the spinal cord level than at the thecal sac level, and it causes different types of symptoms. At the spinal cord level, you get upper motor neuron symptoms, which you guys will learn about at some point. I don't know if you already have or not. At the lower levels, once it's thecal sac, you get lower motor nerve root problems. Compression in the cervical spine and the thoracic spine is really bad. So if you get an MRI and you see someone with a big, nasty disc herniation in their cervical or thoracic spine, you need to go examine them quickly, right? Because deficits happen very quickly. Upper motor neuron issues can affect your balance, can affect your, your ability to write and hold objects. It can cause weakness really quickly. So something that you guys should learn now is where the spinal cord ends and the different kinds of symptoms. So upper motor neuron in cervical and thoracic, lower motor neuron after when the thecal sac starts, right about T12L1. And that's different for everyone. And you can see it here on the MRI. You see this big gray tube here, right? All of a sudden the tube ends, let's see, 5, 4, 3, 2, 1, right at about L1. Okay, and all of a sudden it becomes this wavy stuff. You guys all see that? Right, and so the wavy stuff are all the rootlets floating around in the cerebral spinal fluid. Okay, so at this level that we're thinking, this lady has this new spondylolisthesis. This is the middle here. It doesn't look like there's a whole lot of thecal sac compression, but we're not looking at everything right now. We're looking at one axial cut. We're looking at one sagittal cut. There's another really important cut when you're looking at the spine, and that's parasagittals, which show you the neuroforamen. Okay, you guys see my cursor? These little circles here are the foramen, and this is where the nerve roots exit. Super, super important to look at that when you're looking at spine imaging, because this lady has radiculopathy. The radiculopathy can either be from central or lateral recess stenosis. That's the terminology that we would say middle thecal sac compression, or sort of armpit here thecal sac compression. That's lateral recess compression, or foraminal compression. And the way that you look at the foramen is by scrolling through the sagittals, and you'll see the appropriate axial cut. It's kind of off to the side. You have to look at both sides, and we're noticing here the nerve root should look like a fried egg. It should have a big white space around it, and then there should be a dark thing in the middle. Okay. And, at this level, it looks okay. At this level, it's starting to look like there's some compression, right? And if you know how to look at an MRI, the left side, right, is over here on the MRI, which correlates to this really squished looking neuroforamen. So this patient is having most of their radiculopathy from foraminal stenosis. You guys see how we do that? And so you can have different types of symptoms based on where the compression is. That's a little bit too much information for your level, but if you guys are interested in spine at all, I'd start looking at MRIs of spines whenever you can, and just looking for the basic things that we talked about: vertebral body, the psoas, the facet joints, spinous process right here. These are your paraspinal muscles right here. Okay, and these are things that you should always look for, and look for compression. Right, you'd impress someone significantly if you pointed out that they have spinal stenosis at this level of the game. And so, after looking at all the imaging, my diagnosis was L45, L5 ASD. ASD is an abbreviation for adjacent segment degeneration. We use that terminology anytime someone has breakdown of the next level above or below a previous fusion. So this person had an L5S1 ALIF, right, and pedicle screws, and the level above broke down, because that's what happens in spine surgery, unfortunately. You fuse a level, you put a lot more motion and force through the adjacent level, and it starts to break down. It's almost inevitable. So you have a like 8 to 9% chance of needing an additional surgery every year once you have a spine fusion. So it's a big deal to give someone a fusion, right? And DDD means degenerative disc disease. So that patient's disc was starting to wear. It led to a spondylolisthesis, and both of these combined go under the umbrella of adjacent segment degeneration. These are all new words, probably. You guys, this is like way sort of above the level that you're at, but I want to talk to you guys like how spine surgeons talk. Okay, and so our plan for this was actually a lateral based surgery, and you guys probably have never seen this before. It's called an XLIF. And the cool thing about an XLIF, so this is what we did, right? Here's our inner body, which goes in from the lateral position, right? And you'll notice that we only put screws on one side, all right? And the reason that we did that is because when we were intra-op, we realized that it is not, the spondylolisthesis was stable. And we knew that because when we got an x-ray, when the patient was in the prone position, the vertebrae did not move. Okay, we thought initially that it might be unstable. And because it was sort of a hybrid, we put one screw in, which is not traditional, not the traditional thing that happens, but it's more than acceptable in this case because it's a stable spondylolisthesis. The interesting thing about an XLIF, as I'll go back to the MRI, is the XLIF comes in through the side, through here. So you're going through the psoas to get to the disc. Can anybody think of what a problem going through the psoas would be, trying to get to the disc? That's right, lumbar plexus. So, the lumbar plexus, all these nerves are right in your face when you're doing this. So when we make our incision and we go through the psoas, we have a little probe with an EMG on it that we can spin around. And the probe has a little white mark in it that shows you where your trajectory is. And we look for EMG signals that tell us where the nerves are. If we get all green, we know that the nerves aren't close enough and we can proceed with surgery. If we start getting red signals, you basically have to move your tube and start a different trajectory into the disc space. So that's an XLIF. You guys, I don't think I saw any at Robert Wood when I was there. And so not something that you'll see unless you go to a place that does XLIFs. Not everybody does them. An XLIF is a form of minimally invasive spine surgery. And I want to show you guys a really cool piece of technology that we use to put in these screws. This is called augmetics. And this is a virtual reality assisted MIS technique. And it is wild. You basically put on these virtual reality headset that this guy has on. And as you're looking at the spine in your screen, you're getting the basic navigation view. But this is generally on a monitor in the OR. And in this case, it's just in your face because it's on your virtual reality glasses, which is pretty sweet. So the navigation shows you an axial cut that shows you the trajectory of your screw into the pedicle, into the vertebral body. And it shows you a sagittal cut. So you know your screws are going in the right place. And then under the navigation, this headset creates a 3D representation of the spine. So with all these tools, the cool thing is that you no longer have to dissect the entire spine to be able to put screws in. And if you're not dissecting the spine, you're not stripping off the paraspinal muscles, you're not, violating the interspinous ligaments, you are speeding up recovery tremendously by putting in screws percutaneously. So this really, really cool piece of technology let us put that lady's screw in with an incision like this big in her back. And she left a day later, believe it or not. So this is a new piece of technology. It actually just came out during COVID. They did the first case at Hopkins and the second case at Rush. And now we're doing it pretty regularly at Rush. And it's really, really cool. So I said a lot of words that you guys probably didn't understand for that case. A little bit more of a complex case than, the bread and butter spine stuff. But if you guys have any questions about that at all, feel free to ask. If not, I can keep showing cases. It'll be up to you guys. All right. If nobody has questions, we can show another case. So this one is a cervical case. Pretty wild. So 59-year-old lady, severe neck pain and shooting arm pain. Again, shooting pain into an extremity. Radiculopathy. Okay. That term doesn't change based on where you are in the body. Another sort of thing that can confuse you here is that this lady has chronic weakness in her hand. And so we realized it's because she had an ulnar nerve compression and actually ended up getting an ulnar nerve transposition. So if you're not careful and you're not doing your physical exam right, you could think that she's having radiculopathy and weakness from her spine, and you've inappropriately indicated a surgery too quickly. So you got to be really careful with your physical exam. Okay. Some medical issues that, don't really do anything for our surgery, but the important thing for this lady is that she previously had an ACDF. I don't know if you guys have ever heard that term before, but it means anterior cervical discectomy and fusion. So we go in from the neck here, we move the esophagus and the trachea to the side, we move the carotid to the other side, and we go right down to the neck. and we do our inner bodies that way, which are the things that we talked about in the last case, those little inner body devices. And she also had a posterior cervical spine fusion, which is sort of like the screws that we showed you, but in the cervical spine, they go into a different part of the spine called the lateral mass. So in this lady's case, she was in Brazil. She was in a car, and she got into a car accident, and her neck hurt ever since. And she's had a bunch of spine surgery already. And so, here's a patient that you can easily brush off and say, you've had a ton of spine surgery. You're always going to have pain. And this is where the imaging is super important. So again, our clinical impression, left cervical radiculopathy. And again, radiculopathy is nerve compression causing pain, causing that sciatica type pain. Okay. So looking at this cervical spine, you're probably like, what the hell is going on here? There's a lot going on, and there's a lot going on for even us looking at this. So it's always important to count your levels whenever you're looking at a spine. And in the cervical spine, home base is the dens. And the dens looks much different than everything else. Okay, here's the dens. The dens looks like a big thumb, right? Looks like a thumb sticking up into the rest of the neck here. And so dens is always 2, right? And so we know from her history that she had a 2 to 4 posterior fusion and a 4 to 7 anterior cervical discectomy and fusion. That means each level got an inner body, which you can see these little sideways lines here. And we always back those inner bodies up with plates, right? So she got a big plate in the front. And you'll notice here for the posterior cervical fusion, the screws are way off to the side here. In the cervical spine, screws do not go into pedicles. Not usually. They can at C2 and C1, but we don't have to talk about that. Up here, they generally go into the lateral mass. So we call these lateral mass screws, okay? And so you're looking at all this stuff and you're like, oh, what the hell? This lady has a million reasons to have pain, right? She's had a bunch of surgery. She has hardware everywhere. But this is where you have to really carefully look at your imaging. And I wouldn't expect anybody to be able to see this, but does anyone notice anything funny going on here? If you look here, remember the word that we talked about? Spondylolisthesis, right? So this lady has adjacent segment degeneration, which is one word that we talked about. And we know that because her disc space is completely collapsed and arthritic. So at baseline, we can say this lady has ASD, adjacent segment degeneration. She also has spondylolisthesis, right? And in this case, it's causing radiculopathy. So this is someone who's exhausted all the conservative measures like we always do in spine surgery. She doesn't have any red flag symptoms. So in someone, remember we talked about before, this is the cervical spine. So spondylolisthesis in this case, as the vertebrae slips forward, it starts to compress the spinal cord proper, not the cecal sac. So this can be a major problem. So in these patients, you're looking for gait instability, you're looking for hyperreflexia, you're looking for loss of hand coordination, you're looking for weakness, numbness, tingling, all that stuff. But something like gait instability or real weakness are a reason to operate sooner, okay? So in this case, this lady had none of that. She just had radiculopathy. But it's important to be able to see that spondylolisthesis. So when you're going through your images, you got to look at every single level when it comes to spine, okay? And now we go through her imaging here, and this is a CAT scan. And the CAT scan is important because this patient had a previous fusion, right? So what you're going to do is really going to depend on whether or not this fusion has healed. So whenever you're thinking about spine and adjacent segment degeneration and stuff that's already there, you generally want to see if it's healed or not. If it's not healed, that's a different diagnosis. That's a pseudo arthrosis now. Your plan becomes completely different. In this case, I can see that her inner bodies have healed nicely. This anterior cervical discectomy and fusion is healed nicely. But at the level where she has the spondylolisthesis, if you see my mouse, you see this big sort of black nub in here? That's all this cervical disc pressing into the spinal cord here. And if you look here, this tiny little sort of gray heart, that's the spinal cord. And all of this here is compression. So this lady's spinal cord looks awful at this level. This should be a nice big white fried egg. And she's having severe central cervical stenosis from spondylolisthesis caused by adjacent segment degeneration. So that's how we talk in this field. So all new vocab for you guys. Hope you're ready. So in this case, again, the diagnosis is what we talked about. This lady had a spondylolisthesis, C7, T1, with severe spinal stenosis. So our plan, you have to decompress where there's compression, right? Easy enough. So our plan was to do a laminectomy at C7 to T1, and then extend her posterior cervical fusion to include the spondylolisthesis, which is dynamic. And I remember you check for dynamic spondy with flexion and extension films, okay? So in this case, this lady's neck looks crazy now. So this is what she had before, this is what she had before, and we put these in, okay? So now that we're not in the cervical spine anymore, we're in the thoracic spine. These are all pedicle screws. And at C7, you can also put pedicle screws in. So now this lady's spondylolisthesis has been stabilized. Generally speaking, once you do the laminectomy and once you stabilize the spondy, it is no longer a problem. She woke up, she no longer had radiculopathy, problem solved, right? But now this lady's issue is that her whole spine is fused, right? That's a big problem. See, what percentage of movement was lost? Yeah, so look, when you fuse people's necks, the thing that you're really limiting is their ability to rotate. Okay, so one of my attendings, one of my really scary attendings in residency had a cervical fusion, and he would always be sitting in front of us, and he would turn around and look at us like this, and that used to scare the shit out of everyone. And the reason that he did that was because he had a cervical spine fusion. So they can still flex and extend, and she still can live a normal life, but her rotation is going to be limited. Okay, especially considering that her whole damn spine is fused. Okay, is there any way to prevent adjacent segment degeneration? That's a really great question. And in the cervical spine particularly, especially after you do an ACDF, adjacent segment degeneration happens much more frequently the closer your screw and plate is to the next segment. So generally speaking, we like to have the plate end at the 50-yard line at the vertebral body. The screws don't matter as much, but when that plate goes beyond the 50-yard line, we found that ASD happens significantly more often and occurs more quickly. For posterior cervical fusion, unfortunately, there's not anything you can do. What you can do is not fuse the spine. Cervical spine fusion sucks, but sometimes that's all you can do. And we're not going to go into the indications of when you would do an anterior versus posterior surgery because that's residency level stuff. I didn't learn that till residency. But if whenever you can, you want to try to do an ACDF over a posterior cervical because you can prevent adjacent segment degeneration a little bit more, a little bit better with the ACDF. And posterior neck surgery hurts like hell. These people go on PCAs after surgery and they're miserable. And posterior cervical surgery also has a much higher rate of wound dehiscence because I don't know if you've ever looked at old people, especially, oftentimes our spine patients are overweight. You can see this lady was overweight, just how much soft tissue's back here. That stuff folds up back there and the back of your neck is really dirty and sweaty and you get wound infections all the time. So posterior cervical surgery stinks. What would you say the recovery time for this is? Spine surgery recovery is usually many months, okay? Patients can sort of get back to normal in terms of pain control in 1 to 2 weeks, but getting your life totally back to normal is like a 6-month plus ordeal. And pain is really hard to predict. Everyone's different when it comes to pain. So it's impossible to tell a patient, how quickly after they're not going to have pain anymore. What we tell them is, we're going to give you medication and we're going to control your pain with drugs, basically. And the sooner you get off the drugs, the better for you overall. But it's really hard to predict when that happens for patients. Okay. What's the likelihood of stroke during neck and spinal surgery? Not very high. That's like a catastrophic event. All that stuff is usually less than a 1% chance. But that's why all these people get worked up. Preoperative workup is a huge part of a patient having surgery. So we send all these people to the real doctors. We send them to the medical doctors because God knows an orthopod should not be working up a medicine patient. We check their heart, we check their lungs. If they have a history of blood clots, we put in, a filter, an IVC filter before they have surgery. And so you want to control for as many variables as you can. And if a patient's really sick and they're diabetic and their blood sugar is not well controlled, or they're in like hypertensive emergency, you delay the surgery, right? This spondylolisthesis is not killing this lady. She does not have weakness. She does not have gait instability. So we did surgery on her for quality of life. So you delay surgery as much as you need to optimize a patient, and then operate on them when they're as perfect as they can be. Okay. So yeah, this lady, huge chance she's going to get adjacent segment disease in her thoracic spine. Okay, but she's 60. Oftentimes these people die before ASD becomes a problem. They die in their 80s or 90s or whatever. And just because someone gets ASD doesn't mean it becomes symptomatic. So ASD doesn't matter if you don't have symptoms. It's just a radiographic finding. Okay. So this is like a pretty nutty case. You don't see a lot of that. I have one more case here. It looks like it's 8:20. I don't want to go over too much. So if you guys want to keep asking me questions or you want me to present this case, I'm happy to do whatever. If I don't see questions or hear people talking, I'm just going to keep talking. So I'll sort of leave that up to you guys. Okay. So this is a deformity case. These are huge surgeries. These surgeries are fraught with complication. Some of the literature says as high as 30 to 40% complication risk with a deformity spine surgery. That is ridiculous. That's probably some of the highest complication rates in anything that orthopods do other than tumor work. Okay, so before you do any deformity surgery on a patient, you have to have a really long discussion with them. You have to see them like 10 times. You have to make sure this is ruining their lives. You have to make sure they know all the risks and benefits and can repeat them back to you. Because, if it's not an infection, it's a PE, it's a blood clot. There you go. Another question. That's a good question. How are orthopods different from the spine neurosurgeons? There's a ton of overlap. There's probably 90% overlap, I'd have to say. I'd say as orthopedic surgeons, we're better at fusion surgery because that's how we train. We're trained to do fusions on long bones, and we can apply those same principles to the spine. So generally speaking, we're better at fusion than they are. What they're better at is intradural work. So a lot of times when orthopedic surgeons get a durotomy and cerebral spinal fluid starts leaking everywhere, they're like, crap, get the neurosurgeon in here to come sew this up. It shouldn't be that way. And, as a spine surgeon, you should be able to fix your own durotomies. But when they're really bad, oftentimes we'll call the neurosurgeons in. And if there's like an intradural tumor or, a huge segment of dura that's been ripped off from a trauma, oftentimes we need the neurosurgeons for that kind of work. So the major distinction is intradural work. We don't like the soft thing in the middle. We like all the bones around it. Okay. So once we decompress the dura, we stay the hell away from it. The neurosurgeons start poking at it and taking pictures of it. And, that's kind of what they do. But this is a 28-year-old. AIS is adolescent idiopathic scoliosis. I'm sure you guys have heard of scoliosis before. So this is a 13-year-old who had a 30-degree curve when she was a little kid. Unfortunately, lost the follow-up. 30 degrees is something that has to be watched. Generally speaking, someone that's between 25 and 40 degrees, you want to consider bracing them because their chances of progressing and having a bigger curve as they get older, especially once they're past their growth spurt, goes way up. So unfortunately, this girl should have been treated with a brace, but she was lost to follow-up in her community. And so she's coming to us with progressively worsening back pain and deformity. She thinks that she's actually looking different. And healthy person, which helps a ton. And so in this case, she doesn't have radiculopathy, right? Her problem is progressively worsening back pain that's starting to ruin her life. So my clinical impression is mechanical back pain from her scoliosis. So these are her x-rays, and there's a lot going on here. You guys don't really have to know any of this stuff, but we measure Cobb angles, which is basically an angular measurement of the end plates at the areas of the curve. And, anything greater than 10 degrees is considered scoliosis. We don't care until it's around 20, especially in a child. But once someone's older, 40-degree curve, not a big deal. We start to worry in an older person when the curve's at about 50, because there's usually a curve will progress somewhere between 3 to 5 degrees, 1 to 3 degrees every year. So eventually, as they get older, they can have a pretty big deformity. Right. But in this girl, this is a 28-year-old girl with a 70-degree curve. That is enormous. Okay. She has a double curve. So she has a 70-degree thoracic curve and a 50-degree lumbar curve. It's really important when you're looking at deformity cases to get a standing x-ray and look at the sagittal alignment as well, because you need to look at lumbar lordosis and thoracic kyphosis. Because if those are off and you don't fix them, you've done a huge disservice to the patient and they're going to be miserable. Okay. Lumbar lordosis which is the measurement of sort of the curve of the back down here, is probably the most important measurement in all spine surgery. So everyone that you see ever, if you're going to be a spine surgeon, you should always measure their lumbar lordosis. So this lady's lumbar lordosis and her kyphosis are fine. They're normal. The major important thing when you're going to do a deformity surgery on someone is to know whether or not their deformity is flexible or not, right? Because oftentimes these curves will go right back into position when the patient bends. And if you notice, these x-rays on the right side, these are what we call bending films. So when she bends to the right, her thoracic curve goes down, but it's still huge. When she bends to the left, her lumbar curve almost disappears, right? It almost looks like a straight spine. Can you guys see the difference there? And so when that happens, anytime a curve goes less than 25 degrees on a bending film, we call it a non-structural curve. In a lot of instances, you do not have to fuse a non-structural curve. In her thoracic region, this curve never goes below 25. This is a structural curve. This is what's causing the bulk of her scoliotic deformity. And if you correct that, the lower portion will correct. Okay, and that's one of the really important fundamentals of deformity surgery. Picking your levels is a whole different monster. We won't go over that. There's something called the Lenke classification, L-E-N-K-E. If you guys want to be super gunners, you can read that. It's how we pick our levels, and it's pretty complicated. No one would expect you to know something that in depth. It didn't even show up on our orthopedic boards because of how sort of challenging it is. And so, you know, if this was a little kid, we would get an MRI because little kids aren't supposed to have scoliosis. This is something that usually happens in adolescence, which is why it's called adolescent idiopathic scoliosis. If you see a 10-year-old or a 7-year-old with an obvious scoliotic deformity, MRI immediately, because there's usually something in the cord that's causing the scoliosis, whether it's a tethered cord or a tumor. I don't know if you guys have done any tumor stuff, but there's something called an osteoid osteoma, which is a little bony lesion that can cause the spine to run away from it and cause a scoliosis. But in this case, you know, her kyphosis was a little off, so we called it a hypokyphotic scoliosis. I included the Lenke classification here because this is how we have to talk to each other. This is how the attending expects me to speak to him so that he knows what I'm talking about, and he knows that, you know, I know what I'm talking about. And so in this case, because we decided that she had a structural curve in the thoracic spine and a non-structural curve in the lumbar spine, we did a selective thoracic fusion because the lumbar curve was non-structural. So you don't have to include non-structural curves in the fusion. And so look at that. We fixed her thoracic spine, and the lumbar spine is not a problem anymore. It's pretty crazy how that happens and how the spine is able to accommodate, but that's what flexibility is all about. Okay. And in this case, you know, lumbar lordosis is fine. If you ever have a patient that has a loss of lumbar lordosis, this starts to flatten out, right? We call that flat back. There's a bunch of osteotomies that we can do in the back or take out some ligaments and do an A-lift or inner bodies, which all help to restore the lumbar lordosis. But that's, you know, that's sort of higher level stuff. How long does it take for non-structural curve to correct after the fusion? These images were like 2 weeks post-op. The immediate post-op films looked exactly the same. So it corrects immediately. In correcting a deformity like this, are you ever concerned about the vast change in the hip-spine relationship? Not in this case, because we didn't fuse the lumbar spine and we didn't fuse anything to the sacrum. Whenever you're fusing someone to the sacrum in a huge scoliosis, it's down to the pelvis. Yeah, I mean, you can, if you're not careful with how you're putting in the screws and the position of the spine when you're doing it, you can throw them off. And you can increase the likelihood of them needing a hip replacement earlier on if you're not careful. In this case, though, our fusion is a selective thoracic fusion, so the hip is not involved. But that's a good question. Hip-spine relationship is super important and a hot topic that is like one of the in topics right now in spine surgery. So those are all my cases. You know, you guys can, you know, feel free to ask questions. You know, we can talk about whatever you want. I realize it's 8:30 now, so if you guys got to go, feel free. But, you know, I'll hang around and answer questions as you guys would like.
Question could be about anything, guys. It doesn't have to be related to the cases. Just
Yeah, you can ask me about residency. You can ask me about med school, fellowship. I'm applying for jobs right now. And so I'm getting ready to enter the real world. The job search is crazy. But no pressure. You know, if you guys don't have questions, we'll just end it there. It's sort of up to you. Yeah, my pleasure.
Dr. Lopez, quick question. Thank you for the talk, by the way. So I remember you mentioned that you went in, or you decided spine pretty late into residency. Was there anything you were considering before that? And what kind of made you change your mind pretty late in the game?
Yeah, I wanted to do pediatrics. Kids are awesome. They're hilarious. Kids say the funniest shit you will ever hear in the hospital. And, you know, they're not drug addicts, so they all do well. You know, kids' bones heal. Their kids' bones are like plastic. You put them right back in a position and then they don't have problems. We can heal kids' bones with pins. We don't even have to use screws and stuff, you know, but it was a really hard decision for me because I was really loving pediatrics. And our third year, we go to Boston Children's Hospital and do our pediatric rotation for 6 months. And it was actually while we were there, we do a ton of spine because that's where a lot of our scoliosis training happens. And up to that point in my program, weirdly enough, at the Harvard program, you don't do spine until your 4th year. So the only spine you get is during this pediatrics rotation. And so the people who end up going into spine are people who are like, you know, they know they're going to be orthopedic surgeons. They're like mom and dad are orthopedic surgeons. They know that they want to do spine. They're like, I want to be super rich. I got to do spine, you know? So like those people know early on, but for me, I discovered it because I was so enthusiastic being at the pediatrics hospital. I wanted to do every case I could. And I started doing spine surgeries and I was like, this is awesome. And it was just something that I kind of fell into. There was nothing particularly, you know, like life-changing that happened. I just kept doing the cases. I was good at it. My attendings were making comments that I was good at it. And once I realized that it was something that I was good at and started liking, I just started looking into it more. And once your attendings notice that you take an interest and care and are like excited about doing it, they get excited. And then they start to latch onto you and they're like, yeah, you want to see these spine cases I'm doing? And then like, you should come to my clinic. And that's how you make friends and establish relationships, you know? And so I just so happened to start doing spine surgeries at the pediatrics hospital and started really loving it. But then I realized, you know, you can paralyze kids. And that's like, to me, that's like the scariest thing ever. And so you can paralyze adults too, obviously. But the kinds of surgeries that I'm going to be doing on adults are not these giant deformity surgeries. And so the chance of paralysis is much, much, much lower. But, you know, when you're doing these scoliosis surgeries, you can paralyze someone with just a correction. So all your screws are in place. You correct the spine, all the signals go out, and sometimes they don't come back. You don't really have a good explanation for the family. And, you know, oftentimes these scoliosis surgeries that we do for kids are cosmetic, right? Like kids come in and the parents are like, I don't like the way the spine looks. It looks weird. Granted, you know, if you live your whole life with scoliosis, when you're older, you get arthritis in your back and it hurts, you know, so it's not always cosmetic, but a lot of what we do is cosmetic. And I didn't like that because the risk was too high, in my opinion.
Thank you.
Sure.
What advice would you give for medical students as they start shadowing and then they're in the OR, and how to, you know, show interest, but not, you know, feel like you're in the way of things? Because I feel like, you know, you want to not be asking questions every 5 seconds, but
sure. That is the hardest thing to figure out as a med student. Your job as a med student is to read everybody's mind and to stay out of the way, right? And try to figure out like when you can do stuff. It's impossible. It's like the stupidest thing ever. I don't get it. But the best way that you can show an interest and show that you're prepared is to prepare for the case. All right. Read all the anatomy, especially if it's an orthopedic case. I don't know if you guys know of the Hoppenfeld book, but there's a book called Hoppenfeld's that has a lot of the orthopedic surgical approaches, or you can use Ortho Bullets, which is free. And, you know the major structures that are going to be in the way during your surgery. Know what's around you. Know what nerves innervate what at the area that you're operating at. All it takes is one night of studying. I'm not even joking. Like, you know, you have a total hip tomorrow. Sit down in your room from 7 to 10 and look at all the hip anatomy and watch a video. Watch a hip replacement video. Oftentimes on YouTube, you'll find surgeon quality videos that are incredible. And even in residency, I'm sitting there watching videos, running through the surgery in my own mind, like, okay, That's the tensor fascia. He's cutting through it. Okay, next thing we're going to see is, the greater troch. I should see this, and that. I should look for the piriformis. So in my head, as I'm watching the video, I'm looking at my notes and being like, all right, this is next. This is next. So then one day when you're in the OR and the surgeon's like, hey, what's that? They ask you the one question, your one time to shine. And you're like, that's the piriformis. And you're like, yeah, you get your question right. So in the beginning, honestly, your job is to just kind of stay out of the way. And then once people start to know you and start to realize that you actually have an interest in ortho and care, they'll get you involved. They'll start to ask you questions. They'll start to let you tie. For you, when you're at home, practice your ties, practice throwing sutures, practice, tying knots, practice cutting suture, all the basic stuff. Okay. Knowing how to suture was the one thing in medical school that led to me getting more reps doing other things. So eventually I got into the OR with a resident who was super cool and who was really into teaching and let me do a ton. And he was like, hey, you know how to close? And I was like, yeah, I know how to close. And he's like, show me. So I showed him. I was ready. I knew how to do it because I was practicing at home. Right. So it's not like this is something like mind blowing. Watch videos on how to sew. It's easy. And you can learn on your by yourself at home. And ortho bullets. Ortho bullets is freaking awesome. Right. So just look at whatever topic that you're expected to know for clinic. If you're going to somebody's clinic, look at the clinic ahead of time. And oftentimes their diagnosis will just be in the heading. You don't even have to see the patient yet because they get triaged before clinic. So if you're going to somebody's hand clinic and you see, carpal tunnel, cubital tunnel, hand fracture, at least 3 or 4 things that you can read beforehand so that when it's your time to talk about anything in clinic, you're like, oh, hey, I read this paper about, carpal tunnel, like that. Is this how you do it? That shows that you care, and that you've been reading and that you've been doing stuff away from work. And that'll make people want to teach you more and want to show you more. So, a lot of this stuff happens at home. You can chill, you can, watch TV and hang out, or, if you want to be an orthopod and you want to go somewhere good, like you can keep reading. And I studied a lot. Again, I wasn't a particularly smart person, so I couldn't just like read the thing once and know it like some of these people I went to school with. I had to like do it over and over again, but I always came prepared, and I think it showed.
Thank you. That's really helpful.
For sure. Any chance you could drop your email? Oh yeah, sure. Here, I'll give you guys my Gmail. Oh, wait. That's my Gmail. And that's my phone. Feel free to text me. Don't be offended if I don't respond right away. A lot of times I'm in the OR or fellowship is super busy. So like a lot of times running around, I will respond. I promise. It just might not be right away. But feel free to reach out whenever.
Well, that's it for questions. I want to just thank you so much. That was really both interesting and informative and great to hear from someone who's been in our shoes and moving forward. So we all really appreciate it. And if anyone has any questions, obviously you can talk to Dr. Lopez via email or reach out to any of us on the board if you have questions.
Yeah, my pleasure, guys. Feel free to reach out whenever. Good luck with everything. This is a marathon. All right. Don't try to do everything all at once, and identify mentors. Go hang out in the orthopedic clinic. Go find Dr. McPartland if he's still there. I think he's still there. Dr. Bo. Find the people who want to teach students and hang around and go learn. Go learn something new every day. Okay.